Welcome to all of you wonderful volunteers. And it's a privilege when Mary calls and asks me if I can tell you guys a little bit about what a social worker does. I love talking. I love talking about myself. But most of all, I love talking about how volunteers and the importance they are to our patients and our family members, and tell you just a little bit more about the role of the social worker. And I know some of you have heard my little spiel before, so I'm sorry because some of it hasn't been that long ago, but just consider this a refresher course. I started out actually as a hospice volunteer. I'd moved to San Diego, getting ready to go to graduate school, and I didn't have a job. So I wanted to, instead of spending all the weeks on my own, I enrolled to become a hospice volunteer. So I too took back then it was 32 hours of training that we needed to take. And I remember the first time after I got oriented, I was sitting in the bedroom of a patient. She was 54. She had end-stage lung cancer. And she looked at me, she goes, "Why would you want to sit with someone who was dying?" Well, I like hearing people's stories. You are so much more than you are with this cancer diagnosis. Tell me who you are and what you've done. I like getting to know folks and learning about what they were way before this cancer diagnosis. So that was a good way for me to open up the door. And it was the truth. I've worked in the retirement industry since about 1989, and I worked with elderly folks, and so I've really enjoyed hearing what people's stories are. And so it's a great opportunity for us to be good listeners, and for you to have the opportunity to do that. My goal today is to talk a little bit about the role of the social worker, and I like to keep this an open forum. So if you have any questions, don't hesitate in raising your hand or flagging me down, and to have those questions answered, because I didn't remember later, and I didn't bring anything to write them down. So if you have a question, raise your hand. The social work role starts at the very, very admission time for our hospice patients. We are regulated by Medicare. Actually, the Iowa Inspections and Appeals is our governing agent. We are reimbursed through Medicare. Medicare requires that when a patient comes onto our hospice services, that the core team, the social worker, the nurse, and the chaplain must have a visit to find out what these patients' needs are within 5 days of admission. Of course, we have a lot of other support services with that, with the home health aide and our volunteers and music therapy and pet therapies. But Medicare says you need to go out and find out what is most important to these folks. A lot of times you get out there, they're deer in the headlights because just got the diagnosis maybe 2 weeks ago, or we've just decided that we're not going to treat that. There's a lot of issues. Not only is there pain management issues that our nurse does a really good job at taking care of, but there's emotional issues. Oftentimes folks who are grieving a loss of a loved one or have gotten that diagnosis, they start grieving right then. Well, but their loved one is still alive. And it hasn't been until recently that we realize that oftentimes families go through the emotional grief as if the emotional grief starting to let go of that patient, starting to let go of the future things. So it's our role as the social worker to go in and kind of see what those needs are based on what the patients need, because everybody goes through this differently. I could probably go around the room and ask everyone's voluntary experience, and each and every one would be very different. And the same goes for how a patient, family member, and even family members within each family members are grieving or anticipating the death of their loved one. So we go in there with an open eye, we go in there within 5 days, and we find out what's important. I think it's important that when we're doing this assessment, that your most important skill, and this goes for volunteers, is just to sit and listen. It's really hard for me because I have this agenda of what I need to do to fill out the assessment and document it, and I know kind of maybe what these families need with, she's going to need this or they're going to that. I don't know that. I can assume that, but I don't know that. So I have to kind of take a deep breath. I sit on my hands and I just listen. 9 times out of 10, they're going to tell you what their needs are just in a basic conversation. We explore what their experience is with hospice. We explore what their understanding is of hospice. I tell them about my role. I had a guy on Friday. Why do I need a social worker? Well, we've got the medication and pain the nurse takes care of. The chaplain takes care of the spiritual needs that you might need. And I kind of help the family members as going through the emotional things. Well, why? What do you do? I soon learned that he had a little bit of dementia because he would look at his wife when the answers were coming. But I had to really take a step back and realize he didn't really want me there. And so what I did with that was I kind of threw my agenda out the window because I knew how important it was to develop a quick rapport with him and to let him know that I wasn't here, that he was still the driver. And I told him that, you're still the driver, that he actually was a very well-known man here in Cedar Rapids, a very successful businessman, had started and ran and developed his own company. So he was used to being in charge. So I changed positions and I allowed him to be in charge. So it's really important that you develop a good rapport and finding out what is important to them. By the end of the by the end of the visit, I said, what's important to you right now? He said, well, I'm really worried about my wife. And I said, well, what's important to you? Well, I'm okay with this. I'm going to be gone soon, but I'm really worried about how she and my family is going to handle all of this. And right now what's important is I spend time with my family. So by the end of the visit, he was able to tell me what was important to him, letting him be that driver. So it's important that you listen and develop a quick rapport. The other thing that's one of the other services that we develop through that, and oftentimes when a social worker goes out there and says, well, now we're going to talk about your goals and what your needs are, or what your goals are. Well, you and I know what a goal is. A goal has objectives and interventions that you achieve that. How I phrase that is, what is important to you right now and what do you need right now? So when you're going out there trying to figure out what you're going to do with the patients, it's important that you say, what is important to you right now and how can I help you achieve that, or what can I do to help you obtain that goal? It may be telling you their life story. It may be rubbing lotions on their loved one's hand who can't talk. It may be just sitting and listening. I've also discovered that we've got all these clinicians going in, the social worker and the chaplain, and when the volunteer comes in, there's no agenda. There's no job they have to do. There's no questions they have to ask. So you guys kind of get the job of being a little bit of normal in their life when you do their visits. And oftentimes that's kind of what they're looking for. They're tired of being sick. They're tired of being sick. They're tired of their family coming in. They're tired of being poked and prodded. So when the volunteer goes in, you're kind of like you have no agenda, and they really like a sense of normalcy when they're getting to know you. One other part of my role is to be able to provide resources to these folks. We, Hospice of Mercy, we do provide like a lifeline support. When a patient is living in their home, it's important that they are safe to live there. And so when we go out and do an assessment, we find out what their physical needs are, who's helping them with that. If they don't have those resources in home support, we can provide them with a list of private duty in-home health. We're not 24-hour care. I wish we were, but we're not. So we kind of help give families the resources to fill in the gaps with Lifeline. We also have private duty nursing staff or private duty agencies that we have information with that we allow them to, they can supplement some of the family members because caregiving is really stressful. How many of you have sat with a patient so the caregiver could take a break or go out and get a cup of coffee? You don't know how, and everybody, yeah, a lot of heads nodding. You don't know how valuable that time is. Just imagine. Some of you have probably had kids. Some of you have probably had job responsibilities. Imagine having the responsibility of that care from morning to sunset, 24 hours a day, 7 days a week. We can go, we can visit, we can leave, but these folks are there day in and day out. So oftentimes we can provide, you guys can provide a bit of a respite, relief break for the caregiver, which is very, very important. So we also have, when the patient comes on board, a lot of times they're in a very good place. As a social worker, we explore that. One of our questions is, where would you like to die? What do you think your death will look like? Sometimes people go, I've never thought about that. So we do a lot of the delving in and talking with them about some very, very difficult conversations. The same gentleman who was on Friday, when he first came on board, we said, don't say the H word. Like, what's the H word? Hospice. Okay, I'm a social worker with hospice. How am I going to do that? Pull the family aside. They don't like to talk about hospice or the D word, the death word, in front of Dad. Okay. Well, I tend to go in and do a little exploration. So as I was building rapport with this gentleman, when I asked him what was important, and he said to me his wife and his family was important, he also said, I don't think my family is really getting the reality of this. Now remember, I'm not supposed to say death or dying or hospice. Really? What reality are you talking about? He said, I'm dying. Okay, his wife's eyes got about this big. And she goes, oh honey, we're all dying. We're all dying. And he looks at her, he goes, honey, I'm going to die sooner than you are. And he said, but my kids aren't understanding all of this. I said, well, would you like me to help talk with them about that? Because obviously getting the information initially that the family, they have a hard time talking about that. And that's another support and role. We can facilitate family meetings to help them understand and have those difficult conversations. Sometimes families grow up and they just don't say that word, or that's how they cope and that's how they deal. And that's okay. We honor that and we talk in words and we respect them for where they are. But sometimes the patients, when they bring it up, it's a good opportunity. I don't know if any of you have gotten into that. Have any of you gotten into that conversation about, have you? You want to share a little bit about?
This lady I visited for about 2 years, and the time was coming finally. Mm-hmm. And her husband, he had taken care of her all that time, and he was ready, but they had an older son that wasn't, mm-hmm. and so we talked about that.
Now, was the son present, or did you talk?
No, he was not.
He was not.
He lived out of town. And so the next time he came one day, the two of them had that conversation.
Mm-hmm. Did that together, but you facilitated exploring that kind of as a neutral party and gave them words and tools and things that they needed to be able to have that difficult conversation. Yeah. Yes?
Sometimes when I send a volunteer to a patient home,
mm-hmm.
there's a lockbox.
Oh.
What's the reason for lockbox?
The lockbox on the door?
Yes.
The lockbox is also provided by hospice. It's like a realtor lockbox. Is that the lockbox you're talking about? We hang those on the door. Sometimes patients can't get to the door because of weakness, or maybe their loved one is back providing care. So instead of having to come and answer the door, Hospice of Mercy provides these lockboxes, and the family provides a key for us, just like a realtor does when he's showing a home. So there's a key inside that little lockbox. So there's a code that we can punch, and you'll be instructed on that if you need to use that key. That will be able to access the key and allow us to let ourselves in. That's a good question. What are some of the other resources we provide? Lifeline, lockboxes, home health aides, or private duty aides. Oh, I'm helping a gentleman. I went out to do a visit a couple weeks ago, and he said, I would like to donate my body to science for research. And I said, okay. And so the University of Iowa Health Center works with the Iowa Cremation Society. And so we provide and facilitate them to complete the paperwork. So in the event of his death, then he will donate his body to science. I'm also helping him back to the the tough, difficult patient I visited on Friday. By the end of the session, he said, can you help call the VA? Can you help? He asked me for his help. Can you help me call the VA and see if I'm eligible for any benefits? I said, absolutely. Absolutely, I will do that. So I was able then to contact the VA to find out if he was eligible. Obviously, I'll follow up with that when I go back to do my next visit. We provide ongoing assessments. After we've done the initial assessment within the first 5 days, Medicare requires that we visit our patients on a routine basis 1 or 2 times a month or as needed. And we introduce the folks. There's a lot of visitors coming in initially. Nurses typically go in once or twice a week or as needed. Social workers, chaplains are once or twice a month. And so, that's kind of a big window in order to, until we go back and see them again. But it also gives a little time for folks to get settled into a routine of caregiving and having the nursing visits and whatnot. So by the time we go back in 2 weeks later, a lot of things have really settled down for them. And you can even explore the goals. And you'll probably see this too when you do your visits. But our routine visits are then an ongoing reassessment of what the initial goals were, what they had established, Sometimes those have already been achieved. Maybe they wanted to go to their loved one's graduation that next weekend, so they were able to do that. So then we talk about, okay, what else would you like to do with that? So every 2 weeks, we go out and we do a reassessment. And we're looking at how folks are interacting. My number one question that I like to ask someone after I find out what their needs are is, how do you get through difficult times? It's very important that we find out what their support system is, or what their supports are. Is it faith? Is it family? Is it self? And so when I say what gets you through difficult times, oh, my family, or oh, my faith, or I have friends that I can talk with. So when we learn what keeps them going, when things get tough, we can remind them again, boy, you've gotten some pretty tough news today. Maybe it's time to call your friend Betty, or maybe it's time to schedule a time for the volunteer so you can get out and go do something get away for a little bit. So I always find out we all do, find out what their supports are. I also do that with the caregiver, the person who is providing that care, because it's really important that they know good self-care is very important. And oftentimes they have just come through a year and a half or two of doctor's appointments and visits and health issues and coordinating all of that. The research and evidence shows that sometimes the caregiver forgets to take care of themselves because they're so busy caring for their loved one. Again, another vital point and role of what the volunteer can do, but it's also to remind them, hey, you need to take time. So I find out, what do you do to de-stress? When do you need to walk away? What's important to you to take care of yourself? Because if you don't take care of yourself, then you're not going to be able to take care of the patient or your loved one, and that's going to be, then you both are going to be in trouble with that. So it's important to find out what their supports are, how they get through difficult times, and just remind them of what their self-care needs are. We do a lot of collaboration with the team, the healthcare team, and we do that with phone calls. We do that with we do it with phone messages, but it's important that if I learn something that helps a family get through a difficult time, that I share that with the team. Medicare also requires that we visit them every 2 weeks, but we also have to get together with our medical director, our pharmacist, the nursing team, the chaplain, the social worker, the volunteer coordinator. We all get together every 2 weeks and talk about what the patient's goals are, what's going on for them, and how can we continue to provide support to them. So we take information back to the team meeting, but we also do a lot of collaboration in the morning in the hall when we're sitting back to back getting ready for our day. We talk a lot about what's worked for us, what hasn't worked for us. There was a situation today that a patient went to Chicago and didn't tell us. So we're like, oop, you have to sign a paper. In the event that there would have been an emergency, he would have had to discharge from Iowa Hospice, because we're only licensed to do the counties here in Iowa. So I explained that to him. Well, then I went and I told the nurse, I said, I've already talked to Larry about making sure he lets us know if he goes out of town, that there is some paperwork he needs to fill. So she doesn't have to go out there and tell him about that. So we do a lot of communication within the team, with our phone messages, with direct face-to-face conversations. And don't you know, we have to document all of this. If we didn't have to document, wouldn't we all have more time to do our jobs? It's really cumbersome. And I'm learning to go paperless. And because all of our patients' medical charts are in a computer, I know you guys write something down, send it in to Mary, and she documents all of that. So we document all of our collaboration. When I talk to the nurse about, don't leave town until you tell us, when you document about a visit, Mary's got to put that in the clinical chart, so then when our auditors come in, did you guys know that 5% of all of the direct care to patients need to be done by volunteers? It's a requirement. So they come in and make sure that, I don't know, what's our percentage?
We're at about 12.
We're at about 12. That's good. But Medicare makes sure that 5% of the direct care that's given to patients is done by volunteers. Well, you guys don't have the computer, so you write that down for us. Then you mail that in, and Mary puts that into the clinical record so the state knows how we're managing that 5%. The other thing that you guys need to know that's very important is when Mary comes to those meetings every 2 weeks, she tells us what you guys are all doing on your visits. It's not just a piece of paper that gets documented and put in there.
So that little narrative that you write in there, that's very helpful.
It is. Who said, uh-oh? So don't put anything in there you don't want to be. Well, you all know that already.
And sometimes if it's too long to write,
Mhm.
I can
No change,
take
no
notes.
change.
Yeah. No, 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 no,
I
no.
can take notes and take those with me to the.
She does, and she presents those to our team meetings. We get to hear what you guys are doing. We get to hear, and I didn't ask this person's permission, but the person is in the room. But I'm going to share a little story about what happened with one of our volunteers who picked up on one of our patients' needs. A patient who is homebound, living in her home. Her bed is in her living room. She has a son that's caregiving for her. I asked her one day what her goal was. What's important to you right now? She said, you know, and she's from England. She was born in England. And she says, you know, I'd like to have a tea party. I'm like, oh, okay, sounds good. And I said, what would you like to have at your tea party? And she said, muffins. What kind of muffins would you like? She said, I'd like to have orange muffins. So I took that upon myself to collaborate with the team, and I said, this patient would like to have a tea party with muffins and tea in her home. She has family, very, very supportive family, very caring family, but she doesn't, because of her disease progression, she's not able to get out much. So she used to be an incredibly social person. So we took that upon ourselves to go in as a team to provide her a little socialization. Well, I was talking about it at the front desk, and one of the volunteers piped up and said, does she like flowers? I said, yes, she likes flowers. She loves flowers. Well, would it be okay if I got a bouquet of flowers for that person? And I said, yes, that would be wonderful. So this volunteer took it upon herself then to purchase the flowers, and we presented those to the lady at the tea party. You should have seen her face. Her eyes lit up. She talked about all the colors. In fact, she goes, look how the colors match the napkins. And she was very, very pleased about that. Now, the volunteer is kind of shy. Oh, and I said, now you need to write that down. No, I just wanted to do that. And you guys do really want to do things out of the goodness of your heart. But it's really important that you let us know those little things, because we want to be able to get, not credit, but document the extra help that we're providing to the family members and making a bright spot in a pretty dismal time bright for this lovely patient. So it doesn't mean you all have to go out there and buy flowers for your patients. Please, that's not your role. But certainly it's in the little things of even just sitting and having good conversations that are very, very important to these. And then we hear about these. It's actually going to be printed in our newsletter about the social event that we had for this patient who was homebound, who wanted a tea party. And we're already planning the fall social that she wants to invite her family to. So that's really it's kind of a shoe-in to another nice opportunity to provide support to her. Let's see. Yes?
Do you ever collaborate? I know some of our patients are in facilities.
Yes?
How do we communicate with the staff at the facility?
That's a great question. In the facility, each one of do they sign the book in the blue book? Do they sign in the log that they visited?
The log.
They
If you're
do.
in the facility, the volunteers can write a little note about their visit.
Okay. All right. Hospice of Mercy, when hospice goes in to visit a patient in the facility, some facilities like to keep all their charting in a separate or in their own medical chart, or sometimes we have blue binders where the team goes out and we document where our visits are. And when the volunteers go out, but the family members don't have access to those logs where we document our clinical visits. So we provide a spiral steno notepad into each patient's room with a pen, and this is the book that we chart very briefly about what happened during the visit, because there's oftentimes a lot of family members. We may report to one primary caregiver, but there's a lot of family members who maybe come and interact with grandma, but they don't know, they don't have the communication that we have with the primary caregiver. So it's in the spiral notebook that these folks read about what goes on at our patient visits. So when you go out to visit a patient in a nursing home, it's important that you look for that binder, you date it. I write social work visit on this day, escorted the patient to, or escorted patient, I switch it, escorted, I give her the first name, to Bible study and sat with her, and then I sign my name. And the volunteers are able to do that so they know how many visitors their loved one is getting and a little bit of what happened during those visits. So that's where you document where that happened. It's important that you document that. One time I was sitting in a social work meeting at the hospital with all of the social workers with Mercy Medical Center, and I was sitting there charting, and one of the social workers scooched her chair back and she said, I read what's in that little book. I said, you do? She goes, do you know you're taking care of my grandmother? And I'm like, no. And so, but I had followed up with doing my duty. I could do a little better of it. I forget every once in a while, and it's okay if you do. But I had written down what I had done with her grandma on that visit. And then when she comes in every Sunday, she read through that. She says, you don't know what that means to know that you guys are spending time to do the things that she likes. And so it's really important that we remember to do that in the spiral binder. That kind of leads into another. Yes, sir.
Hi, just real quick. I had a friend, elderly friend, who I became friends with because I escorted him on an honor flight. And we became good friends, and he ended up in a nursing home. And they had a spiral notebook there.
Yeah.
I don't know if it was a hospice, but it wasn't nursing hospice.
Okay.
I don't know if it was, or if it was just the family's idea.
Could be.
But he was sleeping so much that, people were starting to write, remember when, remember when.
Remember when what?
Huh?
When you say remember when, that they had that conversation with him even though he's sleeping?
When we did this. Or
Absolutely.
When we did that, things from the back. And, I wrote a bit about our trip to D.C.
Absolutely.
Things like that.
That's a
Very
good.
nice.
That's a good point. I know Mary talks with the social workers in the team to get a little bit of background about what the patient likes, music, what their jobs were, and things like that, to give you a little bit of a nutshell of what this patient is about, so you at least have something to start the conversation with. And I remember when it's really hard to have a one-sided conversation with someone when you know very little about them. But what I've did, everybody's shaking your head, yes, you've probably had a few of those visits, haven't you? But what I've discovered is I start my day with greeting them, obviously, with who I am and why I'm there. Then I start talking about the day a little bit. Boy, my goodness, it's a hot one today. I had a gentleman who was a farmer. He wasn't able to do anything but give me good eye contact and say yes or no. But I had read in his social history that he'd been a farmer all of his life and that he really, it's a hot day, but you're probably used to having days like this when you are out working in the field. So general knowledge, just expanding on that about what their days would have been. If the patient is able to do some verbal communication, boy, what did you guys do on a hot summer day? Ask them a little bit. Did you go swimming? No. Did you go fishing? No. Did you help your mom can vegetables? Oh yeah. Okay, boom. You've got another topic that you can take down another road. So find out when you ask them what they've done, how they respond to that, and then take your lead from there. Sometimes, a lot of times I tell them what I did over the weekend just to let them know I had busy time with family. Did your family come and visit? So general conversation of just talk with them about what you would do with another friend or acquaintance that you're meeting up with for coffee, just to kind of stimulate those conversations. Those are hard conversations to have. Has anybody ever had a tough time doing that in a facility? Yes?
Last time I live in Medwick, and I take on the 5 patients there in Medwick.
Okay.
And I had a little old lady sign they brought in, had no family around.
Mm-hmm.
Didn't know much about her, and I go, and I try to visit with her. Finally, one of the 4th of July, I went in, and I said, it's the 4th of July. What'd you do on the 4th of July? And she perked up, and she said, oh, they went to town, to the picnic, and the band concert. I said, oh, you lived in the farm. Mm-hmm. And I said, then I'll bet you went to county fairs then. And she sat up, and here's this cute little lady. She said, I showed a pig.
Oh! What a going off on pigs, exactly. You'd be amazing. You're creating moments of remembrance. You're creating moments of feel good. And then you could take that lead and talk. Did she win with that showing of the pig?
Oh, yeah,
exactly. So you could do a little weeding out with them. And I actually have, and I've been meaning to give this to Mary, I have 101 things to do with a patient that has dementia and impairment. So it's the little things, or the lotion. Oftentimes they'll have a photo book in their bedroom already, or if there's a book on the side of the bedstand, that's probably something that's important to them, so pick something up and read like that and find out. But a lot of times there's some cues and clues around. If there's a CD player, pop on that CD and find out what that music is. So take your cues from them and take your cues from the room as well to help them do that. Or call. If you get stuck, give us a call, because then Mary can call the team members and say, hey, what do you guys do with folks? Sometimes they're kind of grumpy. Has anybody ever walked in on a grumpy resident? Because sometimes they're not ready for a visit, and that's okay too. Let's see.
Can you arrange to have pet dogs taken in?
We do have pet therapy. We have pet therapy. There's a program and certification period that criteria they have to meet.
But can they bring their own pet?
The family would have to bring in the pet if it belonged to the volunteer, or if it was a family pet that the patient is well connected with, then the family could bring the pet into the hospital. Yes, just directly into the patient's room.
So what I'm hearing you say is that if I have my own pet that's not certified, I can't take
Right.
that pet to the
Correct.
home visit.
Right. Right. There's a
Family members can bring the patient's pet in to see them, and we have had that happen.
Yeah,
But
frequently.
unless the pet is certified, we can't have a volunteer go in with their pet. There is some training that you have to take in order for the pet to be certified. They want to make sure that its temperament is okay, so it doesn't bite anyone or
have the right
jump
shots.
people and have the right shots and all of that. If you're interested in that, let me know, because I'll hook you up with the program to get it certified.
That's a good question. I talked a little bit earlier about having difficult conversations with family. As the disease is progressing, and I'm sure you guys have seen some of this, when you're going to see physical changes, you're going to see emotional changes, you're going to see changes in how they respond to your questions. And that's really hard for the family members to see. And part of our role, along with the nurse to do the medical, but part of our role as social workers, just to talk with them and explore with them, how are you feeling about all of these the changes that you're seeing? Are you, and a lot of them say, yeah, I'm okay. I've done this before with my parents, or I'm okay with that. But when it gets right down to it, this is another loved one that they're seeing those changes in. So as a patient comes on board and the disease continues to progress, things change. And even when sometimes they say, I'm okay with this. I had one family member who all along, I'm going to be able to do this. I'm going to take care of my loved one. I'm going to take care of his physical needs. I don't need any help. He didn't even have a hospital bed at that time because he was still ambulatory. He didn't have a home health aide or a bath aide. And we honored that caregiver's wife, dutiful wife's goal to take care of her husband's wishes. Well, one morning we get a call. And I got the call. I was getting ready to go out on a visit, and I could hear in her voice it was not the same confident person that I had been talking with for the last 4 months. And she goes, he's changed. And I said, well, what has changed? She goes, he's not talking anymore. And I said, okay, I'll let the nurse, and I talked with my supervisor. I said, we'll send a nurse out right away. And she goes, okay, all right. And I said, Mary, what is it? She goes, he soiled himself, and I can't take care of him. So imagine her wanting to have that goal and then not being able to say that. But listening to her on the phone, I knew that there was something going on that wasn't quite right. So I asked her, and then she was finally able to say, he soiled himself, and I'm not able to do that. I said, I'll be right there. And so the nurse was on her way as well. So things change with family members, and emotions change, and the things they think they're going to be able to say. And you may see some of this out, and that's part of the assessment tool. You're an extra pair of ears and eyes for us as well. So just know that things may change, and emotions may change. I think one of the best questions that you can ask on a visit, because of those changes, what's going on for you today? And take their lead from that. Because it may not be, I want to talk about my life story. I may want to talk about not feeling well. In hospice, if you're not feeling well, that means the end is coming sooner. And so when they're getting those physical signs and symptoms that I'm not feeling well, that can generate a lot of feelings of uncomfortableness and a lot of feelings. So it's important. A good question that you can ask them is, what's going on for you today? Oh, I just had a wonderful weekend with my family. We had a barbecue and we did all this. Or I'm just feeling I had kind of a bummer day yesterday. Well, what was going on yesterday? And the patient was able to tell me that she's getting scared to live alone, but she doesn't know how to talk with her daughter about that. And I said, well, would you like me to be here when you talk to your daughter? Well, yeah, she's got her own life, and all along for 4 months, her goal had been, when she couldn't take care of herself, she's going to move in with her daughter. And so I said, would you like me to talk with you? And so I called, and I said, do you want me to call your daughter? Sure. So right there, I called the daughter. Fortunately, the daughter was able to come over later on that afternoon. And one of our roles is to help facilitate some of those difficult conversations. And all along they knew what the plan was, but just talking about it was really, really hard. So I was able to sit with the daughter, I was able to sit with the patient, letting her tell her what she was feeling and what, the things that she was going through. And it was cute. The daughter said, "All right, Mom, is it time to take the plunge?" Which meant move over to her house and all of her busyness. But able to facilitate that. So their needs are going to change. And again, you're the eyes and ears. You may see that change that no one else has seen yet. That's another reason why it's very important that you kind of get a baseline of where they are and look for the subtle differences. Are their eyes open as much? Are they as talkative? Do they seem as interactive as they were before? Those little things are when those changes occur. It's very, very important that you write down just the differences. We're not even I can't say patient is dyspneic at rest. But what I can say is patient got very winded when he got up from his chair and sat down in his recliner. So things that just, what did you see? He got winded or needed to take deep breaths. Just talk about what you see, and I know Mary you guys have already learned about how to document that, and if you have questions about that, I'm sure she'll address that later. But notice that it's important to know when things are changing and having those tough conversations or bringing it to someone's attention. As a volunteer, has anybody shared with you and they've said, "Whoa, I've never told anybody that before"? Has anybody had that experience? Sometimes they might have that, and then it's important that you report that back to the team to let us know what was coming up. So if you don't feel comfortable in talking with that, or even what you did talk with them, let us know so we can have that ongoing support and continual information, or give that information back to the team as well. One thing that the Hospice of Mercy does as the role of our social worker is to provide bereavement support after the death. So again, Medicare requires that when a patient dies on hospice service, that the hospice follows up with the family for a minimum of 13 months after the death. So that's part of our education and support. This gentleman who was worried about his family and how they were going to respond to his death, I shared with him, our bereavement, our team will follow up with your family with phone call check-ins, grief and loss education. We're going to be with them after you die to provide them support. Oh, that's good. Check that off his list. He's not worried about that anymore because he's the provider. He has normally probably been taking care of all of that. I've just let him know that someone else is going to follow up with that. So our social workers, we follow up with our families after the death of their loved one. We call them within 48 hours to offer condolences. Then our bereavement program is set up that within 30 days, we call them, get a hold of the primary caregiver and anyone else that the team has identified that needs bereavement support. We call them and do another assessment. How are you eating? How are you sleeping? Again, who are your supports? Because a lot of times they've had all this busyness of hospice, they've had all the busyness of family, now the patient is gone. Everybody kind of disperses after a while, and the loved one or the caregiver is kind of left there on their own. So it's important that we check in with them to see how they're doing and provide them support as they seem directed. Research says about 95% of folks get through the grieving process in a normal fashion with grief, sadness, readjusting to new routines, but have the support of family and church to help get them through, and then their own individual supports to help them get through the grieving process. There's only about 5% that need a little more help, whether it be, even if they need a support group, that doesn't mean they're not grieving well, they just need another way to talk about it, or they need another way to get through what they're experiencing. And these 5% that don't grieve well, typically they have another mental health condition, whether it be depression or other illness that they're working with. And that's still even normal. It's just going to take a little bit longer. And we tell them about that. We tell them what their resources are. One of the best things that oftentimes we hear them say is like, "Oh, I'm normal, I'm not going crazy." No, you're grieving. Someone very important to you has just passed away, and it's going to take a little while. Ooh, I've got one couple, 71 years they had been married, and her husband died. I can't imagine what it would be like not to have your companion and your best friend and your husband and your spouse down that road, but we'll check in with her even after the death as well. Any questions about that? I'm either talking too much or I'm saying what I'm supposed to be, but you guys are a good audience, very attentive. I hope I'm telling you what you need to know. Let's see, what else do the social workers do? Meet them where they are. One other thing, this is while they're on our program, we help facilitate transportation you guys have probably all had tours to the hospice house. Medicare provides respite support for these busy family members and caregivers, so we help the nurse facilitate transportation. I had a gentleman this morning, wasn't doing so well at home. The wife was really overwhelmed with care, so we helped coordinate ambulance transportation for the patient to come into the hospice house for 5 nights of respite stay. So then there's 24-hour nursing staff there, there's care staff there, so then the patient's loved one, primary caregiver, can just take a breath and rest. Also, take a step away from the caregiving, allowing her to be the wife for her husband, who probably will die here within the next few days, based on what we're seeing. But just allowing them to be a couple, again, on the last days of his journey. So we help facilitate some of those things. I think that's about all I have. Would someone like to share a story of an experience they had where they either collaborated with the team or back to Mary about an experience they had with one of their patients? Yes.
You were talking about change of emotions.
Yes.
Personal with my wife, and she was in hospice, and she wasn't with Mercy. She was home. And I was leaving that day for work, and she says, "Would you do something before you go to work?" She says, "This doggone dog keeps getting up in bed with me, and I don't want him up here all the time." I said, "Yeah, we can work that out." And the caregiver came. I said, "Just leave the dog where he's at. He's fine. He won't be getting up on the bed." So I go to work, and when I come home, I walk in, and there's a visitor and caregiver, and the dog is on the bed. I went to get the dog off. I says, "What are you doing up there?" And she says, "You leave him alone."
Oh.
Just fine.
Oh. Shifted from the morning to the...
Emotions do change.
Emotions do change, and understanding of things do change. And that's why important is what's going on today. What's going on with you right now? Yes, sir.
I was assigned a patient one time who was in a nursing facility, and I got there at the appointed time and talked to the lady who was there, and she was very cold, very distant.
Mm-hmm.
And said, "Well, you can stay if you want to. I don't need you here." So I said, "Well, I'm here." And we just talked a little bit, and I discovered that unknowns to any of us before that time, this was a very dysfunctional family. So I reported that back, because up to this point, that was not known.
Hadn't heard about that.
But it turned out that there was a lot of dysfunction,
Mm-hmm.
a disagreement, even to the point of lawsuits and things going on. The patient was pretty much oblivious to the whole thing.
Mm-hmm.
It was the family that just couldn't get their act together.
And that's hard to find a good balance. And oftentimes, even as a social worker, I have to take a step back and say, what is my role? What can I do? Who do I need to tell? And I need to let the rest of it go. Because one of the most important things that I've learned in the profession in all my life is just to go in with fresh eyes, no judgment. And that's hard, because we all have ideas of family. We all have ideas about how we would want our death to go. We all have our own preconceived notions. But what's important to remember is the person right in front of you, that's really who we need to listen to. And so I need to throw all of my stuff and all of my judgments and all of my barriers kind of out the door. Some of the houses I go into, they don't smell the best. Some of the houses I go into, boy, if that was my mom, I would probably, but it's not my mom. We look at safety, and that's another thing. I'd briefly touch on that. We do look at safety, and we are mandated reporters. But who defines what is normal? Who defines how that should be? It may not look how I would do it in my home, but this is their home, and we're still a guest in their home, and we're still a guest in our environment. So it's really important you kind of check your stuff at the door, look for the safety things that you need to report. And you know what? The thing about hospice is these folks get along 23 hours a day without us there. You know, we're only there about an hour or two a day to provide, and they function quite well. But that's a good point, and thank you for reporting that, because those are the little things that maybe we hadn't had a chance to hear about. So, and then we'll provide that support as they need it there. I think it's important to remember that no matter how big it is or how little it is, even if it's just, you know, in some of the patients that I chart with in the nursing home, I write down, provided a sense of presence. And people say, what is that? We oftentimes hear that sometimes the hearing is the last to go, or the hearing is the last thing to go. And so their sense of smell, their sense of touch, they still may be there. So it may be when they're not responsive, a gentle touch on the hand or lotion, or gentle words or a prayer or a reading or something. Remember when we used to do those, just reminding them of those things. It can be very, very vital and very, very important, especially at end of life. So even the little things are very, very important when you go out to visit our patients. So thank you for what you do. We admire the service, and we welcome you to the team to be able to provide a very vital and necessary role to our patients and their family members. So thank you for that.